I know.
Dear friends, we will keep going talking about the biomechanics from the window of an orthopedic surgeon, actually. But I was really very impressed from the previous one, and I will try to improve the knowledge about the fixation techniques. Before that, I'm happy to say the first book of the orthopedic study guide has been on the market. It's going to be published maybe within 2 weeks. It's dedicated to only the trainees education. There is no very super complex stuff inside it, starting from the anatomy and also trauma and biomechanics and arthroplasty and everything, but on the level of the trainees. So we are working on the other series of that book. Now the shoulder is on the market, actually. And also, just to inform you, the whole talks are recording, actually, and we are going to make a separate CD, and we'll send you in order to keep it in your data and in your room or library or something. Bless you, Ayas. Okay, there was a big quake here. So, okay, now inside that room, except you, everybody is fixing the bones, right? Is there any guy who never used any plate, any nail, any external fixator, any screw? No, that's the issue. But the most important thing is, really, do we know how do they work? Okay, we put the screw inside the bone and it heals are good and the result is good, you know. So, but the biomechanics of the implants is the most critical part, you know, in terms of treating the defects and bone fracture, actually. So, let's start with a question. There's going to be some questions inside the presentations to wake you up, and this is the first one, actually. Maybe we can be more interactive. Which one do you think is achieving the absolute stability? Which one? This? 1, 2, 3, 4, 5. Who says 1? Anyone? 2? Who says 2? 1, 2. And who says a 3? For the absolute stability. Who says the 4? Okay. And this one? Nobody votes for the external fixator and the pin fixation for the absolute stability. So let's see what is the absolute stability and the relative stability, and then maybe we can discuss the answer of that question later on. Why we are talking for the absolute stability and the relative stability? The absolute stability is a kind of rigid fixation, and the relative stability, you can say they provide just relative stability. So this is the primary bone healing. We write it when we we use the technique for the absolute stability. We get the primary bone healing. And if we put some relative stability stuff, it's going to be secondary bone healing. What are the difference of this stuff? In that treatment option, we do not see callus. Yes. You know, we do not see callus. So how does it happen if there is no callus in the bone healing? It's a huge work of Haversian canals regarding the primary stability of the fracture healing, actually. And on the other hand, you know, endochondral ossification. This is the main issue that the callus tissue mechanism. It starts with the fibrous matrix and then cartilage and calcified cartilage. which means it's a soft, like a kind of soft callus, which existed in the third week after the fracture, after we provided relative stability, and then it converts into woven bone, which looks like a tumor, woven bone, like osteosarcomas. If you take a biopsy from the woven bone after 4 months after the fracture and send to the pathology, almost 9,900, maybe 100%, they are going to say that without any clinical description, they're going to say that it might be an osteosarcoma, but it's not. It's just a healing process. And at the end, we provide the lamellar bone. So here in the secondary bone healing, there are really, very long process to heal. And what do you think? Which one is more stable? I'm gonna, this one or that one? Okay, we will discuss it later. Which kind of healing is more stable and strong regarding the fracture? So here is the primary bone healing. What are the things of the primary bone healing? Absolutely unilateral rigid internal fixation. It cannot tolerate any soft tissue interposition. So in what bones do we use the absolute stability fixation technique? Do you know?
Yes.
Forearm?
Forearm,
Forearms? Low humerus? No? So,
not every time.
huh?
Not every time. I think.
In humerus there might be, but according to the AO,
More in the articular fracture.
yes, this is perfectly right. The articular fractures should be fixed within absolute bone stability, and regarding the extremities, the forearm needs to be fixed because the forearm likely seem to be an intra-articular fracture.
Yes.
Actually, so we don't need any. It's not tolerated any soft tissue interposition, especially in the upper limb. And also, as I mentioned, the Haversian remodeling is the most important point actually. For the secondary bone healing, as I mentioned, there is a callus here. There is an external callus and also internal callus. The exogenous callus is the main mechanical support of the secondary bone healing. So, and remodeling is, according to some papers, the remodeling is ending within 7 years, not 2 years, 7 years. So when a patient show up in your clinic and say, oh, I could still see the fracture line in my x-ray, well, you're going to say the remodeling looks like may end in 7 years. So this is the question of the first, this is the answer of the first question. This is our scale, which is unstable, which means secondary bone healing, and which is super stable, that means primary bone healing. And these are the options that we could use in terms of the current orthopedic treatment fracture options. So let's see. Cast is going here. Casting is the most unstable fixation technique in orthopedic treatment. Let's go to another one, Anders nail. Have you ever heard that? I put it because it's not on the market now. It's a kind of intramedullary nailing without any unscrew, without any locking screws.
Without screws.
Just the original puncture nail.
Yes.
In the ender, you put a lot of
Like a bunch of flowers.
yes.
Titanium elastic nail.
It's a kind of titanium. It's not a titanium. It's a stainless steel. And look, it just provides almost, if you say here 50%, less than 50% for the staple. And now the current intermedullary nail provides much more stable constructs because we have interlocking and we have a different type of sizes. And the bridging plating sits between the nails, and they are almost as stable as the intramedullary nailings, but they provide absolutely on the secondary bone healing process. And look, the bar of the X-fix is very big. You know why? Because it is absolutely depending on your technique. If you use just 2 pins, it's like cast almost, a bit better than. If you use 4-plane, circular, and within a very good manner, you can also provide a primary healing. So that's why the bar is pretty big regarding the other ones. And the last one, this is the answer of our question, actually, when we get back to the question. If it has interfragmentary screws inside the fracture treatment option or design, and plus there is a plate, it becomes the most stable construct that you can ever provide in the bone fracture treatment. So even here there are plates, but you can see there are interfragmentary screws which provides a compression towards the between the bone fragments. It means that this is the kind of most stable fixation regarding these technique choice. So I'm going to get this one, yeah. The bridging, the external fixator, and the compression, plating, and lag screws. So here, you can easily say that it's not like black and white. Never. Now, there is no just primary healing or secondary healing, very few. In our normal, in our like routine fixation techniques, the reality is this side. Even we just try to provide a super organized, like absolute fixation technique, it's almost impossible. At least we will have a micro motions between the fracture sites. So this is the reality, but this is the theoretical stuff, but this is the reality most commonly that we see in the practice. And there are lots of fracture mechanism. We should understand the mechanism in terms of the treatment, actually. So if there's a destruction force, it becomes a transverse. If there's a compression, it becomes an oblique, or sepal fractures. If there is a bending with a compression, at that time the butterfly fragment existed. So and it's just a torsional fracture. There's going to be long spiral fracture that we see in the long bones, actually. So what is the bending load? The bending load is the compression strength. Here, the femur. The lateral side is compression side. The medial side is the tension side for the femur. So that's why when we plate the femur, it's a kind of tension bend technique. That's why we call. It's always asked in the board questions. Which of the following fixation techniques represents the tension band? The femoral shaft fracture fixation from the lateral side is a kind of tension band technique. So if this compression strength is greater than the tensile one, and then it becomes a bending load and bending type fracture. And also the torsion fracture is a kind of oblique fracture, and commonly we see the combined ones. So that's why healing and treating the fracture is not that easy, as we mentioned. So let's move to the biomechanics of the internal fixators. The first internal fixator that we commonly use are the screws. What do we know about the screws, actually? We just know their designs, right? Is it cannulated or not? 3.5, 4.5, 6.5. Okay, open the 5.3, how do you consider it? All full threaded, partial threaded.
Yes.
According to the vendor, sometimes when they say, okay, we don't have a 6.5, can I open the 7? Okay, you can open it.
Yes.
But the reality is not that. This is the practice, but the reality is not. That's not. So we should know the anatomy of the screw if you want to do a nice job, actually. So here is the screw anatomy. It's not very hard, very simple. Just there are lots of variations for the screw, but these are the most important three points of the screw that we should know if you want to use it in a very good way. The outer diameter, we can see it's the outer and the inner diameter and the pitch. How do they work actually? If there are two things that we are expecting from a screw, the one, it shouldn't be broken, and it shouldn't be pulled out. So this is just, we are expecting two things from the screw, nothing more, right? Okay. So if we want to make the screw stronger, we should increase the inner diameter. This is the issue. Like regardless of the out diameter and pitch and anything, the inner diameter is the only thing that affects the strength of the screw. On the other hand, if we talk about the pull-out strength of the screw, actually, we should think about the difference between the outer diameter minus inner diameter. So this is the strength, this is the pull-out strength of the screw. If we use an bigger outer diameter, it's going to be in pull-out, it will be harder. And if we use a less inner diameter, but it compromises the strength of the screw, we will have a less pull-out option. And especially, that's why the cancellous screws has been existed. Because since we don't want to deal with the strength of the screw, we just increase the pitch. If you increase the pitch, the pull-out strength of the screw will increase. So the ideal screw is the screw which is hard and non-broken and less pull-out. This is the question for you guys. The greatest biomechanical difference between unicortical and bicortical locking screws is seen when what force is applied. So, just simplify the question. Why do we use bicortical instead of unicortical screwing? Even it's a locking screw. Because bicortical locking screws has a better compression or better torsion, better destruction, or the other technique of the plate, bending on the side of the plate or the bending on the surface perpendicular to plate. What is the advantage of bicortical screwing than unicortical? Yes, please.
I think the last one.
Bending on the surface perpendicular to the plate.
Yes, bicortical compression. And bicortical, it lies as a good for the bending of the surface perpendicular to the plate.
But just I want to take your attention. It's a locking screw. In the locking screws, do you apply pre-bending? You are right in your perspective if this is not the locking screw actually. We are going to discuss it later. That's absolutely correct. But this is locking screw. So we don't have an option to bend the plate, just maybe 2 degrees or 5 degrees, but even we don't impair the geometry of the, yes?
It's compression.
Compression, it might be compression. Let's check the torsion. It means that's why in the most updated guidelines and also in the AO guidelines especially, they recommend it was started like I started to use the locking screws 15 years ago actually, and always they say, okay, just one unicortical is enough, unicortical is enough, unicortical is enough, and then it started to pull out. I revised a lot, and then we understand that there's something wrong, and especially the torsion force. If you use in lower limb and also in humerus, the torsional force is, especially in the humerus fracture, is higher than the other compressive fracture, things, bicortical screwing become also a gold standard regarding the biomechanical stuff. So this is the video for how does the compression leg screw. Just very simple. But look, here we can see there is a plate. Even there's a plate, there's a micro motion on that side. It's a bending. First, the far cortex is opened within 2.5 screw, and then this is very simple. Just I want to show because it's a kind of like basic stuff. And then the neocortex has been drilled within 4.2, I guess. And then we put the 4.5, and at that time, look, we get the stable construct, like primary stability. And now let's jump into the plate fixation. The most important for regarding the biomechanics of the plate is the height. Actually, okay, the base, the length of the plate is also important, but the height, it is like the bending stiffness, especially proportional to the thickness. It means height of the plate with the third power. So if we increase the height of the plate twice, the biomechanical is going to be increased in 8 times than the other construct. So this is my question. The bone protects the plate or plate protects the bone? What do you think, Because, bone, the plates are not that strong that, carry our weight, as we saw in the previous discussion, actually. So, after my investigations, the answer is the bone protects the plate. So, if there is no bone, the plate's broken. This is very, very important issue, because if there is a severe comminution like here, or if there is a bone loss here, if the bone quality is bad, at that time there's going to be a plate breakage, plate failure. So the best friend of plate is bone, not plate is the best friend of the bone. That's why I always talk to my patients. After 6 months, your plate is going to be an accessory. Just, it's not anymore. It's not working anymore. So we should always consider the bone quality and bone contact, actually. So this is the issue. If there is a gap between the two fragments, somehow after the load bearing, the plate is going to bend, and it's going to get it. We call them FATİH failure, actually. So here, even it does not carry any weights, the stable looks like a very, very construct, but we impair the biology. And in that time also the plate does not work. So we always consider the good bone stocks plus good bone and surrounding tissue biology. Because every plate has an expired date inside the body if the bone healing does not happen. Any of the plate can survive forever as a bone inside the body. So we should consider bone quality, as I mentioned, and the biology regarding the bone fixation stuff. So this is the applied force. There is a bone screw plate relationship. Here we can say maybe in the other I'm going to show you in a diagram in a better way. So there are like several types of configuration of the screw fixation, but the most my residents can recognize that I put like 10 screws for fixation or 6, I just, say this is the screw of the case. This is the screw of the case means like keystone, like on the bridge. And that screw of the case is always the nearest screw that reduces the plate to the bone, actually. So, regarding the fixation techniques, from my side, the key screw is always should be the closest one to the fracture if I want to provide a primary stability. So, look, number of the screws recommended on each side of fracture. Actually, if we are fixing the forearm, 3 screws with 5 or 6 cortices. If we treat the humerus, at least 3, maybe more. In some cases, for the non-unions, I put a double plating technique. It means that like 10 cortices, but it impairs the biology. But you don't have such a great chance to manage this kind of challenge cases. And if we plate the tibia, it should be at least 4 screws each side. It means that like 8 cortices. And for the femur, almost we can put 8 cortices are enough in order to provide an fixation technique. Let's move on to locking plating biomechanics. Actually, before that, this is the question. In a locking plate screw construct, axial forces are borne by which of the following? Axial forces. In the plate, in the screw closest to the fracture, in the screw most distal to the fracture, in the bone plate interface, in the opposite cortex. The question is, when you apply a locking screw to the bone and let patient load on, what part of the plate or the construct carries the most weight? Screw close the fracture plate. It's also a locking plate. Bone plate interface. Screw closest to the fracture. Distal to the fracture. Opposite side. And nobody says plate. Okay. So let's see. We are going to see on a diagram. This is the answer of the question. This is the conventional plate, right? Okay, perfect. This is like trapezoid type screw holes. Actually, we move a couple of we put a couple of screws and then squeeze them. Look, in our first installment and squeezing the plate to the bone, here we can easily, after we squeeze it, we can easily say that the friction interface is starting the whole bone and the plate interface is affected. So, till here, we didn't let patient to load on, right? This is just intraoperatively, which means that biomechanically, these points and the whole has already been started to be under stress. We call them preload, pre-stressed, because stress is this. But now the patient is under general anesthesia. There is no stress anymore, but no. If we put in conventional plate and squeeze it, the patient started to get some pressure. The bone started to work, which we don't like it, because it's a kind of mess. It's not a dynamic stuff. So when we put the patient load on it, it comes bigger and bigger. So if the patient load is less than the friction force is the main stabilization technique for the conventional plate, then it works. But if the patient load is much more than the friction force, and then you get a breakage. It fails. So how does it work in locking plates? We can see the same locking plates, and then we don't have any that much squeezing opportunity because they have their torques, and then they stops, actually. We cannot squeeze more. They fixed to the plate, and then we put the load. Before we are putting the load, recognize the previous slide that there's going to be pre-stressed on the bone, but here it's clear. There is no stress on the bone. No friction, no stress on the bone. And then, if we put the patient load, only these sides are under stressed. And the maximum side is the initial force is going through the plate, not the fracture side at all. So, this was the answer of our question. If the patient load is less than compressive strength of the bone and the plate is going to work. So the question is, in the previous question, in the locking plates, the first stress is carrying by plate. No bone, no periosteum, no far or near cortices, just the plate. That's why the philosophy of the locking screw works like this. Look, this is the stress in the bone with the conventional plate, and this is the no stress in the bone just after fixation intraoperatively. When we get the patient load eventually, there is no preload here, and there is a huge friction preload against the bone. When we compare them, actually, in terms of failure of the screws on the conventional technique, look, we put our plate, and though this box is under stressed, actually, we can say, and also there are additional stresses here, and when we get a load, patient load on the bone, the stresses increases, and then when we increase the load, they started to dance. They switch like this. On the other hand, for the locking screws, we do the same, but actually with the same load, they don't even move anymore because they are fixed to the plate. It's not a bone issue. So the pull-out strength of the regular screws is calculated with the area of these rectangle. And when we check the locking head screws, the field area is much more bigger than the non-locking screws, so we have a larger resistant area. So the pull-out strength of the plate is also much more bigger than the conventional plates. That's why we love always locking plates. Ask to the vendors to bring us a locking plate or something. So, in sum, there is also, of course, biomechanical advantages. The purchase of the screw, the bone is not very critical, except also in osteoporotic bones. Preserving the biology is also very important, and we have an opportunity to fix the fracture in a fixed angle, and we can use it as an internal external fixator. So this is the DCP, means dynamic compression plate, which completely has a friction force onto the periosteum, and this is the bone. This is the plate, low contact dynamic compression plate, LCDCP. It was now they are historical stuff. I don't know, have you ever used LCDCP stuff? Because the most popular is the locking screws, locking plates. This is before the locking. The philosophy was there is just some pins that can touch the periosteum in order to avoid the periosteal damage, actually. So how does it preserve the blood supply? Also, when we get back, the pre-stressed theory started to work in order to impair the periosteum healing and periosteum bleeding. In conventional plate, the bone is pre-stressed and periosteum is strangled. But in the locking plate is pre-stressed. We don't care about the plate, right? If the plate is enough stable and strong, it will work. And if we preserve the biology, that would be perfect. So there is no additional pressure on the plates and on the bone, and also the periosteum preserved. This is what we want regarding the treatment of the fracture. So let's see. There are not just the straight plates. There are lots of anatomic plates also. For instance, it's a kind of distal radial plate. We can say this because on anatomy it looks like that. This is non-locked. This is the locking plate. So we can easily see that when we have an axial load in the conventional plate, in the non-locked plates, we have a displacement even after the surgery. That's why we converted almost whole cases into the locking fixations. We can use the plates as an external fixator. The mentality is the same, actually. So what's the, now we should talk about some surgical techniques of conventional plate and the locking plates. From my side, the X-ray, in a very good surgical technique, the X-ray of the conventional plate is better than the X-ray of the locking plates. Because you say the plate is like holding very far from the bone sometimes, even if the case is good. Because it's a kind of like reflex of the orthopedic surgeons. We like the plate going to the blade and then squeeze it, make any gap between the plate and bone, but it does not work in something like that. So this is the sorry, we got it. Oh, sorry. Yeah. So this is the compression plate. This is the conventional plate. We pre-contour the plate if we want to use it to maintain the anatomy, and then we put the plate according to the geometry and then squeeze them. How does it work in the locking plates? First, in the locking plates, the most hard part is you need to reduce the fracture. You need to reduce the fracture. In the conventional plate, you can reduce the fracture using the screws, like leg screws. You can call the ball to the plate, actually. So, if you don't reduce it, your X-ray will be something like this. So, the most important, instead first, very important issue is we should reduce the fracture and then apply the plate. That's it. Look, the X-ray will be very bad, but the biology is preserved and the biomechanics is better. But X-ray is bad here because there is a gap between the plate and the bone. So, since we are very obsessive surgeons, we created a combi hole technique in order to provide both of them. In the combi hole technique, first we fix the distal fragment, and then we use one non-locking screw to coil the bone to the to move the bone towards the plate, and then put the others. So the step shouldn't be changed. If you change this step, actually, first, not this one. If you try to change this step, if you put the compression screw after the locking screw, you will get a stress rising effect at the basement of the screws, and then you will have a breakage of the screw. So this is one of the other important issue that we can talk about, the fixation technique with locking screws. And this is the question. Locking plate technology is least indicated for which of the following figures? Locking plate technology. 1, 2, 3, 4, 5. Who say 1? So the question is, which of the following cases does not need and treated by locking plates? Which one? This one? Pilon fracture. Who do you use convention plate in pilon fractures, or you prefer much more?
No, I thought it was just by manual.
Oh yeah, okay. It's a kind of pilon fracture, we can say here.
For the forearm fracture, you can use conventional plates. And
Here?
The forearm.
Forearm fracture. Yeah.
No.
Can
I answer?
Yes, please.
The last one, I think, because this one's plateau and forearm is very important for locking script place, and the other one, you can make it in minimally open technique, medial and laterals open, lateral malleolar fracture place, which are locking screws place, and the other one is a distal elbow fracture.
Yes.
Multi-fragmentary elbow fractures must need locking place, I think, but this one maybe you can treat it with a long femoral stem, and because of this, I think.
For you, which one do you prefer?
Cable is not suitable. Everything natural. It's not natural.
Tommaso, what's your opinion about that?
Okay, you can
understand. No, the last one.
Zuckerton technique, you said.
The last one, the periprosthetic fracture. Periprosthetic fracture. You don't prefer to use locking plates. You? Yes, please, Musa. Forearm fracture.
Absolute stability with different plates of plates positioning.
Okay.
They got to be in different places.
Yeah.
But the main idea for the forearm fractures is that you use a conventional plate and you use the distal part of the hole in order to get compression, so you don't need a locking plate.
Yes.
But rotational forces are very high in the rotations of the forearm. What about this?
You need absolute stability to reach healing.
Do you think we need locking plates to provide the absolute stability?
No.
No. Which we can provide absolute just using these screws as well, right? So according to the also AO fixation principles, forearm fractures are suggested to be treated by non-locking plates. Actually, you can use, but it's not the first choice as in the others. You should make an absolute stability, but however you can do, the first choice is the non-locking fixation technique. And this is another question. A 24-year-old female present with a transverse mid-shaft humerus fracture. Which of the following implants would create the most compression on both the far and near cortices? this is the issue that we discussed previously, maybe 10 minutes ago. Compression plate with concave bending, large fragment locking plate with 3 bicortical locking screw proximal distal fracture, intramedullary nail, compression plate with convex bend, and Sarmiento style fracture brace. The first one. Fourth one. So, I think there is confusion about like here is the plate. This is the plate, and if you decide to make this kind of bending, we can say this is concave bending, and the other is a convex bending. So the issue is this. This is very, very historical knowledge regarding the bond plate fixation, because we don't have an opportunity to put leg screws in this kind of transverse fracture. In that case, we can prevent it and then fix it. At that time, it's going to be more and more compressed. What is working length? Have you ever heard about that? Working length. Working length in the plate, in this fixation. Why it is important for us? Huh?
How far the length of the plate should go from the fracture side to as far as it goes to the bone, in order to support to offers better stability.
Yes, yes. The working length is an issue about fracture stability.
Yeah.
So, how does we manage the working length? The working length is the length of the interfragmentary leg screw. The length between 2 screws closest to the fracture on each side. The distance from the bone to the plate. The length from the screw closest to the fracture to the screw furthest from the fracture on the same end of the plate, like this. The length between 2 screws furthest from the fracture on each side of the plate. So, yes, the distance between the closest screw is called the working length. Why it is important? It's good for a test question, as a test question, very good. But it's also, we use it in fracture fixation techniques, actually. So, everybody is doing minimal invasive plate osteosynthesis, actually, right? So, if the working length is increasing, the relative stability of the fracture is also increasing. If, like, think about the external fixators, if the length of the work length is decreased, it's going to be more rigid fixation. It depends on your technique. If it's a transverse fracture, you don't need to have a long working length, because you need a rigid fixation. Stop. And this is another question. How does a DCP accuse compression to the fracture along the bone? I think we already showed that because of the trapezoid stuff. So, in the current technology, we have only 2 or 3 millimeters compression opportunities inside the surgery, right? Just using these kind of combi holes. If there is like 2 millimeter, 1 millimeter gap, and then we can close it. But actually, I have a dream. This car is my dream. We get an accident, and there is a fracture, whatever. It's kind of a forearm or humerus fracture. And my dream is, I can put a plate on it, and the plate is going to compress it. I'm not going to deal with any compression or destruction stuff. So, I already worked about 5 more years about that theory. It seems very easy, but it does really take so many times. So this is the issue. Put the plate, and then take your screwdriver and screw it. Don't care about the destruction, even sometimes angulation, and then go into your plate and compress it and finish it. So this was the theory of our plate. You can say my plate, which is patented from US, from Europe, from Japan, from not Africa. The blade is working like a compression stuff, and also the blade is working as a distractor and fixator, we can say. And also the blade can, if you want to shorten the bone, just put the blade and take the piece out and then compress it. It makes an easy stuff. And then if we want to make a segment transfer, actually, now we are working on it for remote. It's going to make a segment transfer as well. So, and then I did my in vivo studies about that in sheep models in the very sterile conditions. This is the plate. This is the prototype of the plate that we put. I just screw the plate. I'm showing this. You know, it's completely different biomechanics that I told. And then just I put the plate, insert it to the proximal side, and then to the this is checking the plate in plate technique, we can say. And then I screw it, and then while keeping the plate, I take the segment out with an osteotomy, and take the bone. This is, for instance, my defect, and then start to move the bone, actually. So we are going to publish it very soon, and this is the maybe we can call the third or fourth generation of the compression and distraction of the new generative plates, actually. I don't know. So let's move into the a bit nail. I'm getting faster, so I talk a lot. We should, if we are talking about the nail, we should consider about the diameter. If you consider about diameter, very easy. If you put in thicker nail, it's going to be more stable. If you put in narrow, it's going to be non-stable. This is only the rule, actually, regarding the intramedullary nailing. So this was the question at the beginning of my talk. This is the callus bone healing, and this is the without callus bone healing. The callus bone healing is 1.6 times stronger than the normal bone. So this is what we love it. On the other hand, compared with this one, it's almost half less stable than the other issue. That's why, if you provide primary stability, and if you take the plate out, the bone started to break, refracture. I really, regarding my experience, I never see any refracture after removing the nail. I saw a lot of fracture after removing the clavicle, forearm, the humerus. So this might be the reason why it is less stable, actually. So I'm just going to tell, if you increase the diameter, the property biomechanical is going to increase. And this is a kind of this original Küncher nail. Have you ever seen the Küncher nail? It's a kind of a leaf of what? I don't know. This is an open nail, not like that. But so after that we are not using. And also interlocking screws is very important, because the advantages, they provide axial rotation stability and also angular stability, but time and radiation exposure and also stress rising in the nail are the disadvantages of interlocking nails. This is the question. 27 years old, a male undergoes intramedullary nailing with a mixture fracture with a static locking proximally and distally. And then there is a minimal healing noted 3 months post-operative, and decision is made to dynamize the nail. For intramedullary nail dynamization, an interlocking screw should be placed in which of the holes shown here?
A.
Yes, it's very dynamic portion of the long slot. So in some cases, students answer this one because they think that it's going to be played. No, this is the dynamic part of the pattern. And some about external fixators. It's going to be some last topic of talk. The external fixators, actually, the stability depends on the pin size, very huge, and this is the most significant factor in the external fixator stability, the pin size. Not the number of the frames, not the planar of the multiplanar. The pin size is the most important thing because it affects like 4 times more from the others. Of course, number of the pins are also very important. At least we need 2 for proximal and 2 for distal, and 3rd pin will be perfect. If you have 3rd pin, will be perfect. And this is the 3rd pin. And if you have opportunity to send the 3rd pin as a different plane, that would be better than perfect. And pin locations are also very important. And the issue is, if you use not pin wire, the angles between the wires should be 90 degrees. But it's not that easy always, especially in the ankle, because or also in sometimes in the knee it's easy, but in other parts, in forearm or humerus. But the ideal is 90 degrees. No parallels, no 20 degrees. They're going to have some instability inside that. Pre-bend of the pins are not recommended. You don't need to pre-bend the pin, you know, or it should be perpendicular to the bone. Is the most important point actually. And of course, rods, rings, and dynamization is very important. In sum, if you want to increase the stability, increase the pin diameter, increase the number of pins, increase the spread of pins, multiplanar fixation, reduce the bone fragment distance, pre-drill and cooling. Pre-drill is very important. You know what pre-drill means? Pre-drilling means you can just drill and with a smaller diameter, just near cortices, and then send the rod in a very low torsion, not in high speed screw send or something like that. So because cooling is very important also, and also radially preloaded pins, radially 90 degrees of tensioned wires, and of course stacked. So this is the question. After application of the unilateral tibial external fixator, it is observed that the frame does not provide sufficient rigidity across the fracture site. Altering the external fixation in which of the following ways will have the greatest impact on frame stiffness? This is what I say. Increasing the pin diameter is the most important opportunity that you can serve to your patient actually. This is another question. Which has the strongest influence? I think this also the same, we can say. In summary, we should respect the soft tissues, not just think about the bone, putting the bone together. And we should choose the appropriate fixation. Appropriate fixation is the fixation that you feel yourself the most comfortable. You know, from my side, I prefer plating for the humeral fractures rather than the intramedullary nailing because I don't have that much. It's a kind of, you know, according to your feeling you convenient. Both are good. You can prefer the way that you know. Acute stability, length, rotation, control to permit the motion. We operate the patient to return them to their life earlier, not after operation we put in a long cast again. This is not reasonable. You know, otherwise, if we feel all of them on the patient, why do you operate it, right? And we should understand the limitations, requirements of the internal fixators. Thank you very much. Patience. It was a long call, I don't know. Sorry about that. Yes. Any questions before the coffee break? Any questions? Or we've also